Assalamu alaikum. Gentlemen, I am Dr. Asad Farooq and I will be sharing with you my experience of microkeratome assisted DSAC tissue preparation which have been successfully employed at AFIO since last 1 year. First significant breakthrough in lamellar keratoplasty came through the work of Malles, and afterwards many others contributed and made endothelial keratoplasty the dominant surgical treatment for corneal edema. Today we will be discussing DSAC, which is, as you know, the form of lamellar transplant involving selective removal of dysfunctional desmoid membrane and corneal endothelium, replacing it with healthy donor endothelium, DM, and a strip of stroma as well, thus clearing the cornea. This is the cross-sectional view of the post-DSAC eye. Here we can see the transplanted tissue jutting out. These are the main techniques. Today we will be discussing automated microkeratome assisted dissection, details of which will be discussed in subsequent details. Coming to the indications, the mother load comes from pseudophakic bullous keratopathy, Fuchs endothelial corneal dystrophy, post-PK failed grafts, post-TRAB tube and shunts, SHED, posterior polymorphous corneal dystrophy, ICE syndrome, post-traumatic endothelial failure, and post-herpetic endotheliitis. First and foremost is the patient visual symptoms and complaints, most importantly glare, if interfering with daily activities and comfort. There is no upper age limit, but important consideration for children is that the anterior chamber should be large enough for the graft to be safely inserted and positioned. Visual acuity and recovery takes longer in prolonged corneal edema, hence it is suggested that the patient should be counseled forehead. DSAC typically causes hypermetropic shift of 0.75 to 1.5 diopter, hence adjusting for the above in IUL calculation if you are planning triple procedure. In complex eyes like post-glaucoma drainage surgery, vitrectomized eyes, aphakic eyes, and eyes with significant iris loss, DSAC may be a preferable option due to greater surgical ease in these cases as compared to DMAC. To minimize endothelial damage, excessive manipulation of the donor should be avoided while preparing tissue. Secondly, thinner DSAC tissue leads to better visual outcomes. Donor disc diameter should be approximately 3 mm less than the smallest diameter of recipient cornea, and on average it is between 7 to 9 mm. Endothelial cell density greater than 2200 cells per millimeter square is preferred. A smooth stromal surface on DSAC lenticule is desired that is produced with microkeratome as compared to manual dissection. A large diameter scleral size of 16 to 18 mm is preferable to prevent loss of vacuum during microkeratome pass. When preparing DSAC tissue, donor age of 25 or more is more desirable due to increased corneal rigidity. Traditionally, DSAC graft measures 100 to 180 microns. Other thinner variants like ultra-thin DSAC and nano-thin DSAC offer potential of achieving superior visual outcomes and comparable with DMAC. Technique for tissue preparation. Mainly when preparing DSAC tissue, a donor age of approximately 25 years or more may be most desirable due to increased corneal rigidity. Preparation of ultra-thin tissue donor lenticule less than 100 microns may be achieved with either one or two pass methods. In one pass method, we can check the complete pachymetry. For example, it is 550 microns after removal of the epithelium, and then if you desire to have a 100 micron lenticule thickness, you should use 350 microns blade, because generally with 350 microns you will be cutting 400 microns anterior lamella. So the leftover tissue will be around 100 microns. The basic steps. One important aspect is when you mount it on the artificial anterior chamber, you need to pressurize the anterior chamber to 60 millimeter of mercury, and that is achieved by giving the height to the infusion bottle of around 120 centimeter, and then you can clamp the cannula 50 centimeter away from artificial anterior chamber. And if you desire to produce ultra thin and nano thin DSAC tissue, you should use a double pass method. First, you can use 300 microkeratome and single pass, and then again you should measure the pachymetry, and then you can use another blade which are available in the form of 50 microns, 90 microns, 110 microns, and 130 microns. So this is how Moria ALTK system looks like. This is view of my trolley with the Moria ALTK system, artificial anterior chamber, few syringes, handheld pachymeter, eye care tonometer, my case, 64 years old male, he had complicated cataract surgery and developed pseudophakic bullous keratopathy with mid-dilated pupil. His V and left eye was counting finger. So this is the video of surgical steps. Donor cornea prepared and mounted on artificial anterior chamber. Artificial anterior chamber is sealed and pressure is adjusted. Epithelium is scraped off. Pachy is done to confirm the corneal thickness. 350 microns keratome used in this case. Pachy is done again to measure the final corneal thickness, and then underlying tissue marked with the orientation of SRF mark. So this is a bit rough way of doing it. Now we have got S stamp, which is very fine. Donor tissue removed from the artificial anterior chamber and then is refined according to your desired size. Then tissue is loaded into Busen glide and it is ready to be injected into the anterior chamber. On first post-op day, you can see, you can appreciate the margins of the DSAC lenticule inside the anterior chamber, and you see cornea have already started to clear up. And this is the early post-op picture of my patient. You can appreciate the donor lenticule is well opposed and there is no interface fluid. So microkeratome offers a potential advantage with regard to better sizing of the posterior lenticule. It obtains the smooth surface and precise stromal cuts as compared to manual dissection. There is lesser rate of perforation. It can produce ultra thin and nano thin DSAC tissues with the help of dual pass, and which have superior visual outcomes as compared to conventional DSAC, and residual anterior stroma can be used in DALC. With this, I thank you all.
Microkeratome assisted preparation of donor tissue for DSAC. So welcome all of you. We still not seeing the chair. Dr. Mahfouz Hassan is not here. He's gone. Okay. And may I request Professor Hai to please chair this session, because it's okay, no issues. So our next presenter is Professor Khalid Mahmood. If you have time, sir, aapka na. So do we have Tayyab Azim Janjua sir? Please, sir. And his talk is about intraoperative OCT assisted DMAC.
So if you are if you are doing it on on a cornea which is preserved in the fluid, then it will be difficult to assess that how much tissue is left and how much is there. So you have to, I mean, make a readjustment of your thickness accordingly. And the thickness is 750, but
Yes.
actually is 550.
Yes.
And you divide your keratome, I mean, and the remaining tissue with considering this point. And similarly, if you are having this from the eyeball and you are
Okay.
removing a fresh cornea,
Yes.
the edema is less.
Yes.
But if you are receiving cornea from Sri Lanka or other tissue,
Yes.
and then again it is edematous.
Yes.
And now it is, I mean, about 100 micron thicker as is normal. Maybe it's a little bit less or more, but approximate I'm saying. I have not measured the eyeball. But I think if you are going to remove a 350
Yes.
in a cornea which is rotated, which is preserved in fluid, you're going to end up in a 400. That
Yeah.
means if
Yes.
400 will become about 325. So it will be much thicker
Sir-
and it will be
sir,
difficult to do it.
It all depends on the pachymetry. Even in a case we used 550 microkeratome, and when you say you are using 550 microns, it means it will cut till 600 microns, and
Yes.
we did not end
So
up in
that's what
perforation.
I'm trying to emphasize is
Yes.
that instead of having your consideration on the part which is removed, your consideration should be the one which is left,
Yes.
because you are going to,
Exactly.
I mean, to transplant that part of the tissue. So keeping the consideration of this edema. Okay, you are ready?
Sir,
You are just taking, I mean, the time.
thank you very much for giving me an early turn. और आज चूँकि सेशन फौजियों से स्टार्ट हुआ है तो बिल्कुल 9 बजे स्टार्ट हो गया, बल्कि 5 मिनट पहले ही स्टार्ट हो गया ऐसे लगता है। मैं भाग भाग के आ रहा था, लेकिन डेली का एक्सपीरियंस है कि 10 मिनट्स मिल जाएंगे, लेकिन आज नहीं मिले। Sir, Asad is my first fellow, so I'm really proud that he has presented for the first time and he is doing a marvelous job. Every sort of procedure he is doing in AFIO these days. Now my talk is on OCT assisted, live OCT assisted DMAC. Just a glimpse of history. In 2005, they utilized first time this OCT for surgical purposes. At that time, it was not incorporated properly into the microscope, so they used a beam splitter as we use for the student port, and then they utilized OCT. But the problem was that the surgery needed to be paused, because when you turn on the OCT, you couldn't have patient's view. So in 2007, somebody came up with this idea, a portable machine, handheld OCT machine. But again, the problem was the same, that you need to pause the surgery, have a view with OCT, and then resume the surgery. In 2010, it was properly incorporated with the help of Z tracking and focus control into our modern microscopes. In 2018, this study was published with the name of Discover. Most interesting thing is that although we all take intraoperative OCT as a VR tool, and we consider that it's very useful in macular hole surgery and ILM peeling and all that, but what they found was that 43.4% of the anterior segment surgery, they changed their surgical decision due to this intraoperative OCT, while the ratio was almost 29% for posterior segment surgery. So if I say that probably it's more useful as far as anterior segment surgery is concerned, it won't be very wrong. Currently, we have got 3 models. So Hag Street, IOCT, rescan with Carl Zeiss and N-Focus Leica. I don't have any financial interest, but we have got this model with us at AFIO. Now, as you can see, we are operating over here, over the eyepiece, but the screen is hanging over here. So what happens is that when you're doing surgery, this is the view on the screen. So this is surgeon's view, while inclusive this OCT is the screen view. So if you want to look at the OCT, you actually need to take away your head from the eyepiece and look at the screen. So again, the problem is the same, that you need to pause. So what they did was a very smart idea, that they incorporated a small screen into one of the eyepieces, not both. One of the eyepieces, if you click a button in the foot switch, you'll get this window. Now this superimposed image is visible to you, and this is a live OCT. But obviously there is a learning curve, because you need sometimes to suppress that superimposed image and concentrate on your real surgical view. And sometimes you take your attention away from this to the real OCT view. But again, you don't need to move your head away. The uses can be many. Intraoperatively, you can examine the patient before starting the surgery. Once you are removing the epithelium, you can see all this jumbled up epithelium over here. But I mean, these two are not real uses of intraoperative OCT. This you can do even with pre-op OCT. So as you advance your steps in the surgery, you realize that the usefulness of OCT is gaining momentum. So this is descemetorrhexis. Now you can clearly see the instrument over here, and this is going over here and peeling off the endothelium from here. Peeled off endothelium is visible here. Now these red marks, they are the tip of the instrument. So we can clearly see that we are removing the endothelium. Once you have done that, then you can examine all the corners of the descemetorrhexis. Now we all know that sometimes tags are left in the periphery, especially in the regions where they made incisions. So this is probably the area of the side port, and we can see there is still a tag remaining over here. So OCT helps you to identify these tags, which can be removed later on. Then when you inject the scroll, it's probably the most useful step where OCT helps you. So we all know that the scroll will always roll endothelium out. So it has to roll this way. So when we unroll, the endothelium goes down. So for this purpose, we use multiple strategies like F marking, S marking, cutting an arrowhead. But OCT clearly tells you, if you've got one, that which way it's folding. So this is horizontal view and this is vertical view. This arrow is visible over here. So if we look carefully, this is folding like this. So if we unfold it here, we'll be in the right orientation as mentioned here. So if we unfold, this red is actually the endothelium. So endothelium is going to be at the bottom of the graft, which is the right orientation. You can see the cut of the arrowhead over here as well. So I usually cut arrowhead instead of marking S. Again, is this orientation right? For a reference, the same figure. So if we unfold this, this is going to unfold in the wrong direction. So endothelium is going to be up, which means it's going to suffocate between the desmoid membrane and the stroma. So that's not the right orientation. So this is the importance. Yesterday, probably Dr. Noman was mentioning that once you unfold, sometimes you realize that you did it the wrong way. So the S or F marking is not right. And then you inject again, and then you get it folded into the anterior chamber, and then you flip it, and then you unfold. So you've got OCT, even before unfolding, you exactly know that you are not going in the right direction. So you can flip right away. Can you make a guess which way is this? So make a mental guess and compare it with this. So that was the wrong one. But I mean, to me it appears very perfectly, I mean, double scroll and it looks like this, but actually it is the other way. So that's real use of OCT if you've got one. Now, once you have unfolded, you can see some fluid over here between the graft and the residual stroma. Once you have injected the air, then you can move this all around to look into the corners. Now, some abnormality is visible here. Do you remember? This is the area where the residual tag of the recipient endothelium was present, and this is probably the side port in CN. So we removed that, but while removing it, we had to struggle. We had to really, I mean, struggle to remove it. And this is the area which got roughened due to that struggle. But still we can see that there is no overlap between the two tissues. So there should always be some gap between the tissues. If they're overlapping, there is always a chance that it will start scrolling again.
So next presentation will be by Dr. Zaman Shah, and that is about donut refractive lenticular transplantation.
Bismillahirrahmanirrahim. I'm going to present one of the new idea regarding the cornea transplantation, and this is basically the donut refractive lenticule transplantation. Now, whatever the idea is mentioned over here is all from my own, right? So what is donut refractive lenticule transplantation, DRLT? Basically, this is leftover of the round, clear refractive lenticule after the smile procedure. So usually we select a thickness which vary from 100 to 120 micron, but basically the thickness doesn't make any difference. It is the diameter which matter a lot. This is one of the new procedure in the history of the refractive surgery. This is also a corneal procedure as well. So later on we will set our own protocol and indication for this procedure. At the moment, those individual which is ineligible for UV cross linkage, they are usually the best candidate. Individual with high Kmax in thinnest location of more than 350 micron, they are good candidates. Yeah. More than 350. More than 350 up to 300, but less than 350 we don't go for any procedure. Then we will switch to other cornea transplantation procedure. Now our basic aim is to create the negative meniscus, and we want to decrease the topoastigmatism in the Kmax. Now donut should be placed exactly in the region of the cone. Mostly the cone lies either inferior or less commonly they are central. So the donut should be moved accordingly. Donut bone layer transplantation should be done in a similar fashion, and we hope that the result will be maybe more promising. We have not started yet the donut bone membrane transplantation. Now donut edema usually subside by the end of a month. Femtosecond laser assisted bone layer transplantation, usually the edema subside after a month. Now, as far as rejection is concerned, rejection of the donut refractive lenticule, DRLT, so I will be using the terminology DRLT, is there but extremely minimal due to the presence of the keratocytes. Now, rejection of the bone layer is negligible or 0% in manually harvested, as there is no keratocytes, because bone layer contain only collagen. Rejection of the bone layer is there when it is harvested with a femtosecond laser, as it contains some posterior part of the stroma which contain the keratocytes. Again, the rejection is negligible. That's why we rinse the bone layer with the alcohol. So donut bone layer transplantation will be started very soon as well. Now, in case of the manually harvested bone layer, to subside the edema usually take more than 6 months, because there is severe insult occur to the bone layer while manual harvesting. After a month of the donut refractive lenticule transplantation, we can go for CXL to further strengthen the cornea. So it means that after DRLT, we can go for CXL. In case of the femtosecond laser assisted harvesting of the bone marrow layer, again CXL can be carried out after a month because the edema usually subsides after a month. But in case of the manually harvested, usually the CXL can be carried out after 6 months. Now, donor refractive lenticle transplantation, DRLT, can be done in any acute VKC, like as we are doing the bone marrow layer. Other procedure, they are contraindicated in acute VKC, right? So no local or general anesthesia is required. Only we need a topical anesthesia for DRLT. No sutures are required, unlike other lamellar corneal transplantation procedure. So what we want, what is our basic aim? We want to have some improvement of the best corrected visual acuity. We want to slow or stop the progression of the keratoconus, and of course the contact lens tolerance. There is another technique by the name of the CARES, cornea allogenic intrastromal ring segments, right? So DRLT versus CARES. Both DRLT and CARES significantly reduce tope astigmatism and CAMX. CARES cover only one segment of the cornea, but DRLT cover 360 degree around the whole diameter of the cornea. This is the beauty of the DRLT procedure. DRLT provide a significant strength to the cornea. You will all see this in the video. DRLT provide a significant strength to the cornea. We can go for CXL after DRLT after a month, which will further strengthen the cornea and will further slow or stop the progressions of the keratoconus. I'm working on another new procedure, that is allogenic ring lenticule transplantation, ARLT. So that was DRLT, this is ARLT, and the video and the result will be shared with you people very soon, hope in the next conference. ARLT, again a novel technique which significantly reduced tope astigmatism and CAMX. At the moment, topoastigmatism, CAMX, and best corrected visual acuity. Later on, we will be seeing other parameters, like we will look for the corneal biomechanics and the bed display. At the moment, I'm picking these 3-4 points, but there is a lot of the reduction of the other parameters in the cornea as well. Now, again, DRLT versus CARES. CARES can cause visible tissue. There is a big visible tissue leading to symptoms like photophobia and glare and a lot of other complications. And cosmetically, it is unacceptable because the patient all the time looking at the mirror and pointing the eyes and the tissue. DRLT feature hardly visible tissue, often covered sometime with some amount of the dust, making it challenging to clean. It's very difficult to clean those dust. Following DRLT lenticule is difficult even with the slit lamp examination. You want to highlight the boundaries, it's very difficult to follow. CARES procedure using mallet and refine, risk of the corneal perforation is there while you are making the pocket dissection. Both CARES and DRLT are considered safe when performed with the femtosecond laser technology. Now, this is one of the patient. I designed this procedure 11 months ago, right? So look at this patient. This is the pre-op picture, right? This is the post-op day 1 picture. This is post-op after 1 year. And if we look at the parameters, we want to look for keratometry, tope astigmatism, the nest location, CAMX, and of course, we all are interested in the best corrected visual acuity. So look at the post-op day 1 parameter, post-op after 1 year, and the difference is in the tope astigmatism, there is a reduction of the 2.9 diopter, almost 3 diopter, right? And there is no significant change in the thinnest location, right? And CAMX is reduced by 6.5 diopter. So that's why there is an improvement of the visual acuity from 636 to 612 best corrected visual acuity. Look at the anterior segment OCT. You can pinpoint the whole ring, right? So this is the post-up anterior segment OCT on non-donut zone. The whole of the membrane is there. You compare with this. The membrane has started over there. Membrane has started, which stopped at the center and then started again. So this is the anterior segment OCT. Anterior segment OCT on this is the membrane which started, stop over here, and this start again. So it is not present over here. So it means that this is the anterior segment OCT on donut zone. This is again on donut zone, and this is the anterior segment OCT of the other eye, right? We can go to the next step. This patient is from Multan, and I did this procedure for advanced keratoconus. The procedure is DRLT, right? And this was done a month ago. And if you look at, this is the pre-op picture in the right eye. This is the post-op on day 1. And the beauty of this procedure is that you can get the result even on the first post-op day 1. And look at the table. The reading is, there is a significant change in the parameters, right? If you look at the keratometry, the difference is 3.3, 7.6 diopter, and of course the topo astigmatism is reduced by 4.3 diopter. And if you look at the K-max, 13.7, it means 14 diopter K-max reduction. So this not only improved the visual acuity, but the quality of the vision is also improved. This patient was basically counting finger 1 meter, but after on the first post-op day, he was very much happy, and the vision come to 612. Look at the anterior segment OCT. This is again on donut, anterior segment OCT on donut zone. Start, stop in the center, and start again. If you look at the non-donut zone, the whole membrane is running throughout. This is another patient, Mr. Aves. I did 8 months ago, again, case of the advanced keratoconus, and I did both of the eyes, 4 months apart. This is the reading from the left eye, right? And if you look at, there is significant reduction of the topo astigmatism, which is 5 diopter. But look at the K-max, it's only 3. That's why in some individual, there is reduction of the topo, in some individual, there is marked reduction of the K-max. But at the end, you got a good visual acuity. And this patient I did in April, so almost 8-9 months ago. This is the right eye, right? So we did the procedure on the both eyes. If you look at the parameters, again, the topo astigmatism is reduced only by 0.2 diopter. But if you look at the K-max, it is reduced by 9.4 diopter. Again, there is a good improvement of the best corrected visual acuity. This is the pentacam, right? This is for the left eye. This is again post of left eye. This is the pre-op right eye. This is, now we go to another case. This was the patient who has also got advanced keratoconus. I was not happy from the procedure, but look at the parameters. The pre-op pentacam. We did the procedure in the right eye. This is the day 1 picture, and this is the post-op after 6 months, right? And you look at the table, the readings. Actually, the keratometry there is decreased. Topo astigmatism decreased by 5 diopter, and K-max is reduced only by 3.6. And with a pinhole, best corrected visual acuity, and with a pinhole, there is improvement of the vision up to 6.9. This is again, you see, this is on anterior segment OCT on donor zone, and this is on non-donor zone. Now, you look at the video, all the things will be clear in the video, right? This is basically a donut refractive lenticule transplantation. I mentioned some of the parameters in this video as well. And this is the leftover of the smile lenticule. Usually we select a smile lenticule which contain only spherical error, right? Not that of the cylindrical error. The best tissue is from -4 to -6 with some degree of the cylinder. If it is purely cylinder, I don't recommend that at the moment, right? And this is the block which we remove 2 millimeter, 3 millimeter skin biopsy punch, right? And the central part will be used later on for some other procedure. Now this is how to convert this smile lenticule into donut lenticule, right? And this is a case who has got advanced keratoconus with acute sign of the VKC, and we recommend this procedure to go through. And this is with Zeiss machine. We are doing the same femto procedure, but we make the hinge larger. We make the entry wound just 1 or 2 o'clock. This is an area where we make some entry into the stromal tissue. You look at the rest of the area is hinge, while in femto, this small area is a hinge, the rest of the area is free. Actually, the Zeiss machine, we can reach up to the depth of the 120 micron. For the DALC procedure, as sir mentioned, that we can go even for deeper, but in our machine, that facilities is not available right now at the moment. So we mainly keep the depth as 120, and keeping in my mind a new idea that I am transplanting something very close to the bone layer, because all things was in my mind regarding the bone layer. Now this is how the tissue is unfolded, and there is no upside down like as we think in DMEC tissue, right? This only just to spread. The procedure is quite easy. A corneal refractive surgeon can do it easily, and you will have a very good result. If you got a simple case of the keratoconus, my request is not to go for the DELC procedure, because in DELC procedure you apply 15-20 sutures, right? There may be a lot of the vascularization. As yesterday I mentioned the case, you did a very good surgery and you start stromal vascularization, suture infection, right? And you look at how the beautiful procedure is. You do it on topical anesthesia. The patients come from the office and go back to the office as you people claim for the phaco surgery, right? So this is much more easier than the phaco surgery itself. This is much more beautiful procedure than the caries itself. This will gain a popularity, and I think it will be beneficial for the patient. And you will hear some of the patient testimony right at the very end, because we did the procedure on his 2 eyes, and almost more than 8 months has gone. So this is how you go for the procedure. At the end, just 1 minute. You can hear some of the beautiful music as well, right? Now, at the end, I want this was just my view, but you can hear from the patient voice as well, right? And थोड़ा सा ये लास्ट में वो दूसरा बता दे यार. चलो मैं ये बता देता हूँ खुद. चलो 1 मिनट यार, बैक करती हूँ. ये लास्ट में 1-2 सेंटेंसेस है पेशेंट के, वो आप लोग से सुन ले तो मेरे ख्याल में और भी अच्छी बात होगी. नहीं, आपके इलाके का है सर।
आपने डिकोड भी करना फिर हमारे लिए, अगर पठान।
इसलिए आपकी जुबानी से ये आपकी।
मेरा नाम हसन शहजाद है और मेरे छोटे भाई का नाम मोहम्मद अवैस है। हम फैसलाबाद से आए हैं अभी पेशावर में
फैसलाबाद से सर।
डॉक्टर जुमान सर के पास। हमने डॉक्टर साहब की बहुत अच्छी वीडियोस देखी हैं यूट्यूब के ऊपर।
आप लोग
फिर
नहीं देखते,
डॉक्टर
ये तो
साहब
देखता
के
है।
साथ हमारा कांटेक्ट हुआ है और अब भाई की आइज के अंदर केराटोकोनस का इशू था और डॉक्टर साहब ने हमारा ऑपरेट किया है, भाई का ऑपरेट
आप
किया
देखिए
है
सर,
हमें
दोनों
का।
आंखें बिल्कुल
और
शाइन
अब
कर रही
भाई
हैं।
काफ़ी बेहतर महसूस कर रहे हैं और तो में काफ़ी अच्छा हमें सेटिस्फाई किया है ऑपरेट करने के बाद।
थैंक यू वेरी मच सर।
थैंक यू। बेटा माइक दे दीजिएगा।
The correction of the degree of astigmatism or of myopia is unpredictable if you are, I mean, just putting a donut in it, and you if we although we have a pre-operative and post-operative I mean K readings and thickness, it improves as you said, but we cannot predict how much it will improve, how much the myopia will improve, and how much the astigmatism will improve.
Actually, sir,
And can we do it? I mean, just so
actually, sir, you
brainstorming.
can see that already the patient is high myope, right? Because the cornea is very steep. So we are making the cornea, the central periphery, a bit less steeper. So there is improvement, right? So of course the astigmatism and the other refractive, they get decreased. That's why the vision is improved. But at the moment we are not looking to these parameters because
Giving sorry to interrupt you. Giving the example of the intracorneal rings, we select the ring according to the astigmatism, according to the area of the and the position of the rings are accordingly. And although sometimes the results are not like we are thinking and predicting, but still we have got some scientific reason or some the placement of the rings, the thickness of the rings, and the number of the rings. And so I'm just giving you a hint or a brainstorming for you, that because you have invented all this type. So keeping in mind, can we have a donut of different thickness or different width according to the astigmatism,
yes, sir.
and according to the thickness of the cornea in different parts?
We will set up our own protocols and we will do further study on your recommendation as well.
Yeah. Thank you.
Sir?
Thank you.
Zaman, this is a wonderful technique, but there are a lot of questions actually. The first was that Professor Hai actually mentioned that you actually still don't have any parameters.
Yes.
What amount of the thickness of the lenticule you have to implant. My question is that how do you get these lenticules, number one, and when you get the lenticules from a donor, you ask your friend or you yourself prepare this lenticule?
Actually, this is the liftover or the smile lenticule, right? And whatever the procedure I'm doing or my friend is doing, usually we collect.
So this is actually what I'm going to emphasize.
Yeah.
That if you request your friend, suppose I request you or Tanveer or Tayyab, that please give me the leftover lenticules,
Right.
then do you perform any type of the test on that particular patient?
Like
Serology, which is very important, because if you are getting the lenticule from a patient who is seropositive
Yeah.
for C or B or something like that, even HIV, because when we actually request our eye bank to provide us the tissue, donor tissue, they give us a list of the lab tests. So they are all included in the donor tissue. So do you have any protocol?
Yes,
Number one.
whatever the procedure I'm doing in any operation theater, I usually go for viral profile.
Because, let me complete, because let me complete.
HBS and CV and
Routinely-
HIV as well.
Routinely, when we go for the refractive surgery, I don't think any of my
Yeah,
friends
yeah.
goes for the lab test.
Nobody is going, yes.
For the femtolasic or
Yeah,
for the PRK,
yeah.
we don't go for the any lab test.
Yeah.
But this is a donor tissue which you are going to transplant
yeah.
from one eye to another a particular patient.
yeah.
So this is very important. Number
Yeah.
three is
In our hospital, it is the protocol in FIU Peshawar that any refractive patient should undergo a viral profile including HIV. So we test for all those patients.
okay. The second question is that you performed a central punch of 2 millimeter, you said.
All right.
So that 2 millimeter rests on the pupillary area?
No.
It's
no.
so this is the point that we use the term, this is pupil dependent or pupil independent.
This,
So this 2 millimeter does cover the pupillary margins or not?
no, we are not putting this around the pupil margins. We are putting this around the cone.
No. But the central 2 millimeter which you punched,
Punch,
where
yeah.
that rests?
The center, it will rest around the cone. Around the cone, not the pupil.
So that
This is not
also,
for-
that
this is
also
not-
covers some amount of some part of the cornea? Pupil?
whatever it's cover any part of the pupil, iris, what else, but we put that free area around the cone, right? Because that is our aim, and we want to create the negative meniscus. Until and unless we don't create that negative meniscus, the result, we will not acquire the result.
Yes. Yes.
Right.
So that will get clear?
No,
Because you said the basic difference between the Keras and the DRLT is that the Keras can cause glare and photophobia.
Yeah.
I don't think that causes.
But I
in
mentioned-
many of the cases,
I
when we do
mentioned- I mentioned-
Keras, we have actually two segments of the
Yeah,
Keras,
yeah.
and that doesn't cause actually, usually should not, because we put these away from the pupillary margin.
All right.
So if any part of this lenticule that touches or covers the part of the
It's
pupil,
so
that gives some glare or not.
it's so transparent that I mentioned in my talks that even with a slit lamp, if you want to follow, you cannot follow the margin. You cannot follow the margin. So that's why it is so transparent, thin tissue. Yeah, yeah. Yeah. You will try, and if you see the cases, you will do your maximum try to follow the margins.
Dr. Zaman, I'm sorry we are taking too much of your time, but it's a new procedure, so there are a lot many questions. Now, when we thicken periphery of the cornea, theoretically it flattens the cornea,
Yeah.
and that's the principle behind Kyers and all those procedures. Now, when you are flattening all around, it is supposed to flatten the steep meridian as well as the flat meridian.
Yeah,
Flattening of the steep meridian was visible in all your cases.
yeah,
But flattening of the existing flat meridian
meridian.
was variable.
Yeah.
For example, the patient Shima, it was in the other direction.
Yeah.
The flat meridian got steeper.
yeah,
In patient Avas,
Yeah.
it remained the same.
Yeah.
And in previous two patients, it flattened.
yeah.
So how are you going to be sure what behavior the flat meridian is going to show with this 360-degree procedure?
Next time when we do the procedure, usually we divide them into segments, right?
All
And
right.
we will look at which area is steep and which
put it
area
over there.
is flat. If some area is flat,
are going
usually
to
we don't
avoid
apply
that.
the tissue. We will cut from that region.
Then
like
it
as we
will
are,
become more
we are
like-
doing the semi-demic, quadridemic. So on that fashion, we will convert this procedure
So
as well.
then actually it will going to mimic more like Kyers, because
Yeah,
the principle would become the same, that you actually only thicken the steep meridian and don't touch the flat meridian. So the principle would become
That's
the same.
why I'm now switching to that new technique which I have mentioned, ARLT, that will be somehow like similar with the CARES. Anyhow, if you look at the procedure and the visual result, it's quite good.
Thank you, Dr. Zaman Shah,
Thank
for
you very
your
much.
excellent talk.
Thank you very much, sir.
The next talk will be by Professor Khalid Mahmood, and he will make DMAC easy for us by taking preloaded tissue.
Bismillahirrahmanirrahim. This is an old topic actually. relatively old topic as compared to the DRLT. So DMAC, I'm Dr. Khalid Mahmood, Bismillahirrahmanirrahim, and I'm working in Avicenna Medical College, and I'm also the president-elect for the CAP. As you know, actually, I'm not going into the details of the history of the endothelial keratoplasty or something like that. As you know, in 1998, actually, Malles, he performed the first PLK using the air bubble, and then finally in 2007, the Malles performed the first DMAC, which is called the Descemet's membrane endothelial keratoplasty. What are the indications for this procedure? Is Fuchs is the most common indication in West, but here what I see during the last 9 years of my DMAC surgery course, I started DMAC in 2015. I saw the bullous keratopathy, either it is a pseudophakic or aphakic bullous keratopathy. That is the most common cause in Pakistan as compared to the Fuchs in the other regions of the world, particularly the West. Then we can do the secondary DMAC under field penetrating keratoplasty. The other relatively uncommon, they are the posterior polymorphous endothelial dystrophy and eyes, and we can have the congenital hereditary endothelial dystrophies. These are the basic principle when you are going to perform the, you must know what is the ideal patient and what is the ideal eye. You must prefer, particularly initially, when you are going to perform the DMAC procedure, is that there should be no or minimal scarring of the cornea. When usually the patient reach us, they have developed the scarring of the cornea because they present us too late after they having the bullous keratopathy or something like that. The patient should have pseudophakia because the intraocular lens that actually acts as a scaffold where we want to unscroll the DMAC tissue. The pupil should be, and ideally it should be small and it should be round. Initial cases, you can select the Fuchs, or otherwise in our region, we can select for the pseudophakic bullous keratopathy. The patients who needs early visual recovery as compared to the penetrating keratoplasty or other procedures. And very important is that the post-operatively, the patient have to lie spine. So the patient can lie spine for a longer period of the time because we actually inject the gas into the anterior chamber to actually fix the graft under the cornea, so the patient have to lie spine. Initially, we should avoid aphakic patients because there is no scaffold as told. Tubes, was a relative indications. As long back we started the phacoemulsification, and there were many contraindications or relative contraindications to the phacoemulsification. Particularly when my actually dissertation was on phacoemulsification, and in that phacoemulsification, the contraindication is still written, that was the hard cataracts. But during the time now, we do phacoemulsification on almost every case. So the AGVs was initially considered to be contraindication, or don't do DMAC in the AGV when you have tube in the eye. But now I will show a video where I did the DMAC in case where I have the tube. Or post-trabeculectomy in vitrectomatized eye, we actually don't have a positive pressure from behind. So you should avoid such cases where you have a vitrectomy, pars plana vitrectomy done. In the patients where we have the deep anterior chamber, particularly in high myopes, we have a difficulty to control the anterior chamber fluid currents, and we should ideally, initially particularly, we should not go for the DMAC surgery. My topic is that we have to make the DMAC easy. Why? How? By the pre-punch tissue. Yesterday we actually conducted a workshop on the DMAC tissue preparation, and everybody knows who performed the DMAC that the tissue gets some tear when we prepare or harvest the donor tissue. So when we get the pre-point tissue, it stresses out of the tissue preparation. It shortens the operating time. We have, or surgeon have, a precise focus on the surgical procedure. No risk of off-center, incomplete, or overextended punching. No risk of tears, and we are provided with the orientation marks, that is the S or F, to have the correct orientation and centration of the graft. So DMAC preloaded, that makes my life and everybody's life easy. And I have developed these, the 5 Ps. They are pre-stripped, pre-cut, or pre-sized. You can have any size from even 7.25 or 7.5 to 8.25 millimeter. It is a pre-stamped S mark for the graft orientation, pre-stained with the trypan blue, and preloaded. I get my tissue in Strico modified John's tube from my eye bank. I will go straight away to the videos. So this is the case of pseudophakic bullous keratopathy. We remove the epithelium to have a clear view of the inside. You know, I have done the inferior iridectomy, that's the peripheral and inferior iridectomy. Now I am doing the decimeter axis to remove the decimus membrane. I have marked 8 millimeter. You can see this removing of the decimus membrane. This is the Cellus spatula, which makes the decimus membrane, you can see here. This is the decimeter axis. And now I'm going to inject this tissue, and now we have to unroll. I have this 4-glass cannula with me. This is a 2-way cannula. You can see the S mark here. यार ये बंद हो गया खुद ही. अच्छा, उसमें चलें. So this is another case where we have a failed penetrating keratoplasty. You can see here, I'm doing the inferior iridectomy. In this case, you can see I am getting a little bit difficulty in having the decimeter axis. And this is very important because you have the donor and host junction there. So be very careful. You can see here the decimus membrane endothelium removed. So few air bubbles are in it. I have removed the air bubble and then going to unscroll. This is a very tricky and challenging cases when you do the DMAC under a failed graft, because you have little space, and then you can see here I'm injecting the FS6. You can see the S mark. This is the case where I have, you can see here the tube in it, here, the valve is implanted. I have, this is the myostat to constrict the pupil and to remove the PES. Then I'm going to cut this tube, long tube, to become it smaller, that should not come in the way of my graft. Look at this. So this is the inferior iridectomy I'm doing. This is the unfolding of the graft. Finally, the graft is in position, and I'm going to inject the FS6 gas for limbus to limbus. The patient have to lie spine. Look at this. In this particularly clip, this is the clip of just 20 seconds. You can see here the graft is upside down. Have you seen? The S is inverted. Yes, inverted. So we have to actually roll back. We have to, then again, you can see here, I'm just, yes, look at this. So now, just a gush of fluid, and now it is in the right position to unfold. Now you can see the right orientation of the S. I'm skipping this video. You can see here the very smart use of anterior segment OCT shown by Colonel Tayyab, that you can see here the, look at this. You will see here the graft, look at this. The graft is detached. And when we have to rebubble, and after rebubbling, you can see here in this case, the graft is fully attached now. So I usually rebubble on the 5th day, and my rebubble actually is about 25 to 30%. So I have to rebubble again. These are the few cases which I shown you. This is the case, the first case. This is the case in which there was a tube in the case, and this is the post-operative. You can see, very nice, you can see the inferior iodectomy. Basically, this inferior iodectomy is to avoid the pupil block when we actually inject these SF6. So, over the 9 years, when I started performing my DMAC cases, this 92 years old lady, she is one of the happiest of my patients. When I started my presentation, I said that when you are going to have the ideal patient, there should be no scarring or minimal scarring on the cornea. But look at this. The cornea is, yes, scarring of the cornea. Look at this. She is 92 years old, and her granddaughter, actually, she's a faculty at LSE. She Googled this DMAC procedure, and she came to me that we want this DMAC procedure on our grandmother eye. I requested, please go for the penetrating. They said no. The penetrating keratoplasty has got sutures, 16 sutures in place. We are not going to have this penetrating keratoplasty on our grandmother's eye. So this was a challenge actually. And you can see here, I performed this DMAC, and look at this post-op. She is still 6'24" roundabout. And the best thing is that she can read and recite the Quran. And that's the best part of it. And she is a very happy patient, and I'm happy. Definitely, DMAC has some complications. Incomplete decimetorexis, we can have difficult unscrolling, upside down graft, which I showed you in the video. And post-operative, we can have the graft detachment. We can, then again, we have to refill the gas. Sometimes we have to refill the gas more than twice. There could be pupil block. Inferior iridectomy does actually allows not to get the pupil block, but sometimes I have one patient in which the gas actually traverses back through the pupil. And the next day when I saw again there was a collapse of the anterior chamber, then I have to go under the graft, remove the gas from the pupil margins, and then rebubble this. So we can have the graft failure early or late. and we have minimal chances actually, because in the DMAC there is no stroma, so we have the minimum chances of graft rejection, particularly as compared to the DSAC. So to conclude is, my talk is that what I found is that during this DMAC courses, the cost effectiveness is the most important factor when we have these preloaded tissues with us. The preloaded tissues are 3 or more times most costly as compared when we get the tissue, routine tissue, and we harvest. But the other factors and other advantages of that, we don't have the tear, it stresses out, it shortens the length of your procedure time, you focus your surgery more, and I still believe and recommend that the preloaded tissue is still the best choice if your patient can afford. And the other thing is that usually I myself, the number of DMAC is definitely lower as compared to the penetrating, or we have the keratoconic patients, as Professor Zaman has done beautiful surgeries of the lamellar keratoplasties or DRLT or ART. So we have lesser patients because we have now very good surgeons, phacosurgeons with us. So we have actually less number of patients who have pseudophakic bullous keratopathies. And definitely the cost effectiveness is one of the major factor. And I have come across that we ourselves, when we prepare, the number of the surgeries is less as compared to our eye bank persons who actually these tissue harvest, or they do this preparation of the tissue on a regular basis. So they are more experienced. So I will prefer, and I still prefer, the preloaded tissues. And that's end of my talk. Thank you very much. If you have any questions or...
Thank you, Professor Khalid, for an excellent presentation. I think one question, please. Beta mic dena.
You can, but usually in my practice, because FS6 gas is actually very easy to get. We have the great surgeon, VR surgeon, Kashif Iqbal is here, he's sitting. We worked together at LRBT for many, many years. I worked with Tariq Khan. I think FS6 gas, we have easy to get this FS6. So I have good experience with SF6, and relatively I think that I don't have much number of graft detachments when I go for the FS6. Tayyab is here, Zaman, they can share their views about the gas, but I don't actually, I didn't use C3F8, but you can. Well, a lot of people, I think they have started using C3F8 because it's lasts longer in the anterior chamber. Huh?
The thermodynamic effects are almost the same.
Mm-hmm.
Except that it takes a very long time. CTF8 sometimes can be there even after CTF8 in vitreous cavity can be there even after more than 2 months actually.
Mm.
I don't know about the AC. Ali Saab would know about that.
Actually, we use 20%.
20%.
Yes, we use 20% FS6.
Yes, 20%.
That actually goes away within a week.
Should be within a week. It should be more than half gone, and 2 weeks it should be not be there. But C3F8, if we use it in 16%, or 14% or 16%, and it goes away in 6 or more weeks. C3F8 from the vitreous cavity.
How do you manage mismatch between
Mic dena beta.
because sometimes if the segment is smaller and you get a tissue which is like 8 or 8.5, then how will you manage?
Then I always request.
Specific size.
Yes.
So
I
how do you
always
measure
request.
preoperatively? Like you go
Yes,
for
I measure.
too wide?
I measure with the slit beam of my slit lamp. Usually, I never go. Initially, I was having 8 millimeter or like that, but with the passage of time, I reduced the size with my experience. Now my preference is 7.5 to 7.75. The particular case of the failed PK, actually I was happy to reproduce the record of that patient. That patient has got 7.5 and 8 millimeter. In that particular case, I use 7.25 of the graft size. Because
one thing I would like to mention, that recently I have attended a course in USA regarding the DMAC, right? And that was a private hospital, and Jack Parker is in the habit of using larger diameter graft from limbus to limbus.
Yes.
So of course I asked him, why you are using so much large diameter graft? He tell me that he basically told me that actually want to transplant more endothelial cells. So we should, I think, transplant more endothelial cells.
Yes, this is a good point. But the problem with the larger graft is that these larger grafts, there is science behind it. The size of the graft, there is a definite science behind it. Particularly, you see that in some of the DMAC cases, we use the term, this is DVAC. So we are not going to implant the endothelium. So keratoplasty without the endothelium. The Fuchs people, they have their endothelium damaged or guttata more in the center of the cornea. If you look at the periphery of the cornea, in Fuchs particularly, the center of the cornea, they have the guttae, but the periphery of the cornea, they are clear. So still, if you go and if you do the specular microscopy, you will find out that the peripheral part of the cornea is relatively clear in those cases. So this is the science that you don't want to have a larger diameter of 8 or 8.5 millimeter. So majority of the surgeons who are performing the DMAC, maybe few of them, they are going for the larger diameter to have more endothelial cell count. But the periphery of the cornea, still we have some of the healthy endothelium there. So 7.5, 7.75 or 8 is enough. You don't. The other point is that when you have a larger diameter of the graft of the DMAC tissue, it is difficult to unscroll, number one. And sometimes these grafts, in my experience, they get stuck up into the anterior chamber angle. And then you have to actually push it back again and again. You have to have the gush of the fluid.
And interestingly, I asked the same question, that why you are using so much large graft. So that was basically when the graft pinned at the angle, he told me that I can easily unfold the graft.
You can also, but this is actually a practical point. This is a practical point that you definitely have difficulty in unfolding the graft. And number two, you don't need, because you know, when we started the DULC, the same actually happened there. We started the lamellar graft about 7.5, 7.75, but now the people, they are doing the lamellar grafts 8.5, and they are very happy. So things, they become change in hands to hands. Surgeon preferences, they change. Their experience, they improvise the technique, but there are pros and cons of every modifications or every innovation of every technique.
Sir, regarding sizing of the DMAC scroll, generally it is recommended that if the patient having Fuchs endothelial dystrophy, you should keep it small, as you have already mentioned. But if, because they have more healthy cells in the periphery, but if it is pseudophakic bullous keratopathy, then you can plan a larger size graft.
Yes, you can plan 8 millimeter or 7.75.
Because in pseudophakic bullous keratopathy, you know, the cell loss is till limbus, so patient will be getting more.
You can change your plan. As I showed you, I changed my plan during when I did the DMAC under the PK. So the PK size was 7.5, and as we know, that we have 0.5 millimeter size of the graft lesser than what you have the decimeter axis to have the clear attachment.
Sir. Recently, sir, I did one such case in which there was previous PK and the patient was having TRAB as well. So I discussed with Kaltaya. He said, okay, go ahead and let's see. And once I measured the tissue, the actual size of the graft, it was 7 millimeter. And then, you know, I did rexes like 0.25 inside the margin. And then I was left with only 6.25 or 6.50 millimeter option. So I decided to go for 6.25 millimeter so that detachment is less. And that patient is 6/24, and previously he was counting finger, and it was only eye.
But Asad, in that case particularly, if you measure from behind, from the up or top side of the cornea, and if you measure from the underside of the cornea, there is a difference. So I think still we have very little amount of the patients who have got this 6.5 or 7 millimeter of the recipient cornea and discrepancy of usually we perform 7.5 or 7.8 millimeter. But one more point is to emphasize is that when you are going to plan the DMAC under the penetrating keratoplasty, you must have removed all of the sutures. In one case, actually, when I performed the decimeter axis, there was one suture placed, and my reverse Sinski that entangled in from the inner side of that suture. So it was very difficult to actually disengage the reverse Sinski. So then I noticed that we should have removal of all sutures when we're going to have this DMAC under the PK.
Sir,
who would not do decimeter at all in PKP cases, because there is a theory that probably the endothelial cells have already undergone apoptosis, so there are no viable endothelial cells left over there. So it's just the desmoid membrane. So you can place another desmoid membrane over it.
That was the actually point. I think it was in American Academy. This point actually raised there. Are you going to have the decimeter axis in these cases? The point was there some surgeons, they said that there is difficulty in attaching the graft to the already diseased, yes. Then that was the reason.
That is, I think, basically true more for the DSEC rather than for the DMIC, right?
Sir, as the CAP is concerned and you are the president-elect, so do you think that we should be introducing the DVAC and ROC inhibitors in Pakistan? Are they really necessary? This procedure, is this worthy?
If you are ready and you have the tissues available with you, then you can go for a study. Actually, in my experiences, and they will actually second me, we have very less incidence of fuchs in our country. So, but still we can actually remove the central 3 or 4 millimeter of the tissue from the inside, that is the diseased endothelium, and then we can watch that the periphery actually that takes over. Because the idea behind is that if you remove the center 3 or 4 millimeter of the diseased endothelium, the idea is that the peripheral endothelium, they actually, take the function of that. So that the area.
So can we do it without ROC inhibitors? Because I read a study in which they mentioned
everything actually is practical, but that actually depends that do you have these agents in Pakistan available or not? We don't have actually. So we actually saw the Japanese guy who actually injected the endothelium cells in the interior chamber.
Kinoshita?
हाँ ठीक है ना, वो तो उसने एंडोथेलियम के सेल्स उसने इंटीरियर चैम्बर में इम्प्लांट कर दिए, but we don't have. So what we have, then we have to do it.
Sir, this drug is available with the name of Glenatec in developed countries, and it is being made by Kowa company.
Coa.
And Coa company is here in Pakistan now, and they are marketing their IOLs. So yesterday I met the guy and I told him that if they can introduce Clinatech in Pakistan, it will be a good addition, and then we can have some study
Great.
on it.
Great. Thank you very much.
Okay. I think we have a very healthy discussion at the end of the session. With this, this session is concluded. Thank you very much, all the speakers, for sharing their expertise with the audience, and thank you all.